Welcome. My name is Giacomo Grasselli from Milan, and we have to discuss the risks of non-invasive respiratory support in COVID-19 patients. These are my conflicts of interest. So why should we use non-invasive support in COVID-19 patients? Well, because we know that non-invasive support is superior to standard oxygen in patients with acute hypoxemic respiratory failure, because we know that patients on non-invasive support have lower sedation needs compared to patients during invasive mechanical ventilation. We know that if the non-invasive support succeeds, the patients have an improved outcome because they avoid intubation and all the complications related to intubation, and which is very important during pandemics when we have an important shortage of ICU beds. Non-invasive support can be performed outside the ICU, which is a very important point. And this is a very recent meta-analysis published in JAMA, again, showing that non-invasive support, both high-flow non-invasive positive pressure ventilation and CPAP, helmet CPAP, are superior to standard oxygen in patients with acute hypoxemic respiratory failure, both with regards to all-cause mortality and intubation rate. And the rapid guidelines issued by the Surviving Sepsis Campaign working group on the management of COVID-19 basically suggest to start a trial of non-invasive support, and in particular they suggest high-flow nasal oxygen in all patients with acute hypoxemic respiratory failure from COVID-19 who do not require immediate intubation. But what is very, very important is that they recommend close monitoring of the patients for worsening of respiratory status in order to avoid delayed intubation. So which are the risks of non-invasive ventilation and non-invasive support in the management of COVID-19 patients? Well, the first one is the risk of failure and of delayed intubation. The second one is that we lose control on the ventilatory pattern and on the effort of the patient. And the third one is, of course, environmental contamination and risks of nosocomial transmission of the disease. So with regards of failure and delayed intubation, we know that non-invasive management of acute hypoxemic respiratory failure is flowed by a high percentage of failure. For example, in the LungSafe database of almost 3,000 patients with ARDS, 15% were managed with non-invasive ventilation as first-line therapy, and the non-invasive approach failed in more than 40% of patients with moderate to severe ARDS, and patients who failed had a much higher hospital mortality compared to patients in whom NIV succeeded, and ICU mortality was significantly higher in patients treated with NIV when their PF ratio was below 150 millimeters of mercury. So we know that the non-invasive management of acute hypoxemic respiratory failure carries a certain very high risk of failure. Again, literature data on non-invasive management of acute hypoxemic respiratory failure are conflicting. High failure rate is higher in more severe patients, and particularly in patients with a diagnosis of ARDS, multiple organ failure, or higher severity scores. And what we know is that delayed intubation is associated with mortality. And this is our recent paper published in JAMA Internal Medicine on almost 4,000 patients managed in the ICUs in Lombardy during the COVID-19 outbreak. And about 10% of the patients managed with of the patients admitted to the ICU in Lombardy were managed with NIV at ICU admission. And those patients had lower mortality than patients who were on invasive mechanical ventilation at admission. And half of them failed, and of course the mortality of the patients who failed was significantly was similar to that of the patients who were managed with invasive mechanical ventilation, while the mortality of patients who succeeded in NIV was significantly lower. We also performed a single-day prevalence study, and I'm going to show you the preliminary results of this study, which is now submitted for publication. This was a single-day prevalence study on the use of non-invasive respiratory supports outside the ICU in 31 hospitals in Lombardy. And on the day of the study, we identified more than 900 patients who received the NIV outside the ICU. The study was performed in Italy, so the vast majority of those patients was on CPAP, and in most of them, CPAP was applied through a helmet, as you can see, almost 70%, a very low proportion of high flow nasal oxygen. And on the day of the study, an almost equal number of patients was treated in the ICUs of the participating hospitals. And these are the results of the study. NIV failed in 37% of the patients. 15% of them were intubated after 5 days of NIV, while the remaining basically died without intubation because they had a decision of limitation of care. And as you can see, patients who failed NIV had higher mean FiO2, a higher PEEP level, a lower PF ratio, and a lower PCO2, higher respiratory rate, and higher frequency of use of accessory respiratory muscles, indicating a higher respiratory drive, as expected. And also in our case series, as you can see, mortality was significantly higher in patients with PF ratio below 150 millimeters of mercury, just as in the data from Bellani from the LungSafe study. Then there is the issue of that during NIV, we have less control on the ventilatory pattern and on the effort. So there is the risk of ventilation-induced lung injury due to the application of excessive tidal volume and transpulmonary pressure to the lung parenchyma. This is a very important study by Guillaume Carteau, published in Critical Care Medicine, and he investigated the causes of NIV failure compared to NIV success in patients with hypoxemic respiratory failure, and he identified a threshold of tidal volume. And basically in this study, he showed that patients who developed a tidal volume higher than 9.5 ml per kilo of ideal body weight had a higher risk of failure because those patients had lower respiratory system compliance, so higher tidal volume corresponded to the application of higher transpulmonary pressure. And as we know, patient on non-invasive ventilation with preserved inspiratory efforts and very high drive enter into this vicious circle that leads to the so-called patient self-inflicted lung injury. And again, it's a vicious circle between increased respiratory drive, capillary leak, lung edema, impaired gas exchange, and this leads to high tidal volume, high transpulmonary pressure, very negative value of alveolar pressure, and this leads to patient self-inflicted lung injury. The third point, which is very important during outbreaks of infectious disease, is the risk of environmental contamination and of nosocomial transmission of the disease. So several studies have addressed this issue. There are studies showing that NIV and chest physiotherapy are droplets and not aerosol generating procedures. So droplets are higher than 10 micrometers in diameters, and they fall out within 1 meter from the patient. Clearly, all NIV interfaces may be associated with substantial exposure to exhaled air within a 1 meter radius from the patient. And there are studies showing that dispersion of the droplets during high flow nasal cannula and nasal pillow CPAP is basically limited, and it's almost negligible during face mask CPAP if a good sealing, a good fitting between the interface and the face of the patient is secured. There are studies showing that environmental contamination is similar during high flow and during standard oxygen therapy. And clearly, what we know is that post-helmet is probably a good solution because helmet with a good seal around the neck is associated with reduced dispersion compared to NIV with face mask or compared to high flow nasal oxygen. And what is a plus of the helmet interface is that antiviral filters can be applied at the outlet port of the helmet, like in this slide. As you can see, this is an antiviral filter which is applied between the outlet port of the helmet and the PEEP valve. And this clearly improves the safety of this configuration. And this is a paper just published in Pulmonology that compares the maximum exhaled air distance in meters from mask for non-invasive positive pressure ventilation or CPAP, different types of mask, and the helmet. And as you can see, the helmet is associated with negligible dispersion in the environment around the patient. So in conclusion, we can say that patients failing standard oxygen and not needing immediate intubation are good candidates to a trial of an IV. Helmet CPAP may offer some advantages compared to face masks and high flow oxygen, especially in particular to reduce the risk of environmental contamination. And clearly, since non-invasive management of acute respiratory failure is associated with a high risk of failure, and since delayed intubation is associated with increased mortality, what is of paramount importance is that patients must be continuously and carefully monitored to timely detect signs of failure and to proceed to timely intubation in case of failure. Thank you very much for the attention.